So thank you very much for inviting me, and as you all know, I am a representative of the profession that you hardly want to meet, because you don't want to see infections, of course, in your patients, and your patients don't want to meet me either. And sometimes, though, they do. And I must say I have very little experience from plastic surgery and from breast augmentations and reductions, because we don't see very many of those patients. The biofilm problem is mainly in arthroplasty, as we see them in most patients, and there I have had some experience through the years. And I'm also very happy to hear that there is a registry starting in plastic surgery, and since we do have that in arthroplasty, and I think we gain a very lot of knowledge from this. So we have already heard from Roger Wikström a lot about the microbial community in the biofilm, and I don't have to go into this in any detail. It has been known for quite a long time. Tony Christina, an orthopedic surgeon from South Carolina, I think, or North Carolina, he was really working a lot on these surface interactions and the biofilm formation. And with all the new types of implants in humans that have been really become very common since the 1990s, we do encounter a lot of biofilm problems. We see that in arthroplasty, we see it in vascular graft infections, and of course in all the kind of indwelling devices that we're using in medicine. The natural way of microbial growth is actually in biofilms, and we have already heard that, and these are problems but also used in various ways, because they can help in cleaning processes also for industrial in industrial sites. And we have all found them. Everyone who has seen a boat underneath know that there are biofilms formed, and the shear forces, maybe you think, well, if it's there is no flow, maybe there will be less biofilm, but actually the biofilm seems to be even more dense if there is shear flow to the surface. And as we know, dental plaques, where we have not only streptococci but a lot of other bacteria, and kidney stone and bone sequesters are places where biofilm naturally forms in our bodies. And then we have all the indwelling devices, and we encounter the blood-borne infections. That's very often what we see. We see endocarditis, and of course then we look for the local infection that could have started this. I would also say as a comment that the dental plaques and dental procedures is something we try to avoid in patients who have had an arthroplasty. So for the first 3 months after an arthroplasty, it's advised not to do any greater dental work, and maybe that is something, since we heard about this also from the Finnish colleague, that maybe you should avoid dental procedures if possible, or have it done before you do the cosmetic surgery or the aesthetic surgery. And we know from central lines that there is a difference. It's mainly outside during the first day that the biofilm forms, and then it's inside also. And of course, when we do cultures, we don't do them from a site that might have been infected already. There are so many different types of foreign materials and foreign surfaces, and I will just show you here to the left the vocal cord prosthesis, where you can see a biofilm that has been formed on it. And under the electron micrograph, you can also see that there are an abundance of different types of microbes. These are the ones that have been studied most, the coagulase negative staphylococci, Staph aureus, including the MRSA, which we fortunately in Scandinavia see very little of. and also Propionibacterium acnes, and that is much harder to culture. So it has actually in arthroplasty been something that has quite recently been regarded as pathogenic, because these belong to the ones that formerly were culture negative. Enterococci, both fecalis and the more resistant faecium, are common, as well as Pseudomonas. And what we could do to minimize the risk of an infection is, of course, not to do any surgery if we have any kind of skin lesion. And this is, of course, just a list of different types of skin diseases or skin infections that you should avoid. And, of course, you should not do any surgery on an infected patient. In arthroplasty, it's very common, of course, that patients can be, the surgery is being stopped, because when the patient comes, sometimes even to the operating theater, you find that they have a skin defect, and then you know that you will have problems if you do surgery in those patients. In a study from Sweden, there was culturing of bacteria in lactating women, both of those that had infections of the breast and those who didn't, and they had the same type of bacteria. And there was a little bit of difference, because there were more group B streptococci, which in some cases are quite virulent in the patients who had mastitis or an abscess in the breast. But as you see, there are several bacteria that can be found normally, and these are all in the nipple area. And of course, these bacteria are not only found in lactating women, but also in women. Totally, you will find coagulase negative staphylococci, sometimes Staph aureus also. We all have coagulase negative staphylococci on our bodies, and there are different types depending on what site you are culturing. So we have different ones behind the ears, from under the in the armpits, and so on. Staph aureus, though, approximately 1/3 of us have Staph aureus continuously, and if we work in a hospital or if we are patient in a hospital, we tend to have more Staph aureus, because there is some kind of a pressure from the surrounding. In Scandinavia, coagulase negative staphylococci are often resistant to methicillin, to isoxazolyl penicillin. So they are actually in the treatment a greater problem for us than Staph aureus. And Staph aureus are more primary virulent, so you will actually notice the infection much earlier. So for us, coagulase negative staphylococci is a big problem, because there is much less inflammatory response also with these bacteria. So you should, when you think about treating or prophylaxis for these patients, you have to consider your antimicrobial resistance, both for the patient in the local area, nationally, and also if you have patients from abroad. And we see that more and more, especially in southern Sweden, where I now work, that we have patient tourism. Patients go abroad and have surgery, and sometimes they come back with an infection with a resistant bacterial strain that has not appeared yet in our own local community. But we can also have local outbreaks. In southern Sweden, we have had a very great streptococcal outbreak last summer, and surgical ward and operating theater had to be closed for some time, because we had several cases of severe streptococcal infection and even necrotizing fasciitis. So these could be really bad problems when appearing. As we've heard, there is also not only the TLR receptors are involved, but the biofilm inhibits T cell proliferation and also the monocytes. It interferes with the B cells and the antibody production, which are also important in the opsonization process when the macrophages are there and the neutrophils are there to take care of the antibodies. So there will be a problem for the host cells to take care of the bacteria. The bacteria also have an alternative phenotype. You can really see it sometimes when you look at the growth. The growth is can be very different if you are able to somehow grow bacteria as if on a biofilm. Normally, they will only be like the small cultures that P.O. Nyström showed on the agar plate. But if you can have them growing, it can be really like a bulky substance. And when they grow like this, we know that there is much less effect on them with certain antibiotics. Vancomycin and aminoglycosides have very little effect. Some beta-lactams may work, and some other antimicrobials do work. And I will give you some examples from bacteria. These are now enterococci, and these are bacteria from Sweden. And as you can see, MIC is the minimal inhibitory concentration in the planktonic phase of bacteria. That's normally what we get as a result from the lab when we ask for antibiotic sensitivity. And as you can see, those figures are quite low to the left. Ampicillin, vancomycin, linezolid, ciprofloxacin, and rifampin. When we have a biofilm that has been formed, we have the microbial biofilm eliminating concentration, MBEC. You can see that we have a very much higher concentration needed to eradicate the biofilm. If we add to these antibiotics to the left, rifampicin, which is used a lot already, and there has been several studies on arthroplasty infections, there is a reduction in the MBEC, but it's not coming back to the MIC of the planktonic bacteria. So we do have a problem in treating these. Newer antibiotics have also been added, as you can see for the Enterococcus faecium, that has also been studied in the same lab, where daptomycin and tigecycline has been added. And with some of these, you come down to almost sensitive concentrations when you treat the patients, but you don't really know for how long you have to treat. And it's usually, as we heard, the surface bacteria that will be killed. And we don't know how many mutators there will be in the rest of the bacteria. This is what I already talked about. And mutations, even in Aftonbladet, a Swedish daily evening magazine, all that has headlines that usually make patients very worried. You can probably have discussions from your patients when something like this has been in the newspaper. There are mutator bacteria, and they are always there in a bacterial community. And if you treat so that these mutator bacteria are the ones that survive, you will have mutations in the next generations. And what we do know is that if we use rifampicin alone, we will have resistance within very few generations. And other things that are important in the antibiotic sensitivity, as we know that we have small colony variants. When we grow these bacteria on normal agar, they will not look like the normal bacteria. So they have been overseen. They have been regarded as non-virulent strains in the microbial lab. They grow very slowly, and it is only when they divide that we actually can target them with our antibiotics. There is a nutrient deprivation in the biofilm, which also make them grow slow grower, but the small colony variants don't need that much nutrients. And then we have increased conjugation frequency, which can also transfer resistance, and therefore I think maybe a little bit controversial to what P.O. Nyström said, that still what is now very important are the hygiene precautions, because there is very little we can do about the spreading of antibiotic resistance globally. We get resistant strains from places where there is no control of antibiotic use. So even if we try to be very careful, we might have these bacteria here spreading in the hospitals. When I was working in Uppsala, we had a spread of an very resistant Klebsiella SBL, and it costed the hospital 35 million Swedish kronor to eradicate it. And it's one patient that was coming in with this bacteria. So we can have big problems. So if we do surgery that is not a life-saving procedure, we have to consider what is the risk and what is the cost for our procedure, of course. So to avoid biofilm formation, well, extremely accurate hygiene procedures, and of course no surgery on infected patients. And then of course there are all of these other things that we can do: antibiotics, disinfectants, povidone. Some other surface modulations have started to be studied a little bit. The quorum sensing has now been studied more, and we know that somehow that it can be blocked, but it's nothing that it's far from clinical use. We can disrupt the biofilm. It's very, very sensitive to histamine, but that is of course nothing you can give to the patient, because you will have many other problems. But maybe there will be new modalities to use. And I think that the Finnish study was very interesting to see if we can maybe locally use antibiotics, and I would very much like to see it without the levofloxacin, of course, because quinolones is nothing that we want to use a lot as infectious disease physicians. So thank you very much.